presentation of anticonvulsant in 60 minutes. The purpose of this lecture slides is to increase confidence in dealing with AEDs, offering the practical knowledge of AED, prevention against panic for you. Now, indication of AED is obviously seizure. Epilepsy is an indication of AED. Epilepsy is defined as unprovoked seizure spells with and without EEG electrographic evidence. Epileptic seizure is tendency to have a multiple seizure spell without provoking. AED is also used for non-epileptic indication like migraine, neuralgia, phantom limb pain, RSD, and bipolar disorder and tremor. I do not discuss a non-epileptic indication of AED in this lecture. How do you start AEDs? If not acute loading, always start from the small dose. That way, you may avoid the toxic side effect in most of the case. Hasty dose escalation deprives the patient from the adequate benefit of anticonvulsant, especially newer generation AEDs. Each AED is too precious to lose by side effect due to inadvertent initial dose. Do you have to check the blood level if a patient came back to you with a seizure? Oh yes, of course, in the first and second generation AEDs. Always check the blood level, make sure that the blood level in the therapeutic range. However, in third generation AED, blood level is not mandatory because serum level is not good indicator for efficacy. When it works, it works. You may increase the maintenance dose if patients do not experience a symptom of overdosage. Monotherapy is always recommended at the beginning. It makes sense to use multiple AEDs if needed, which have a different pharmacological mechanism to avoid the redundancy. Add-on improved a very small fraction. Now let's start individual anticonvulsants. First one is phenobarbital. What's good in phenobarbital and what's bad? But first of all, phenobarbital is good because inexpensive. A $3 to $5 a month supply. And it's most prevalent in the world. 97% of AED available on this planet is phenobarbital. Phenobarbital is sodium channel blocker and have a linear pharmacokinetics, which means that if you double up the dose, the blood level double up. It's easy to use. What's bad in the phenobarbital? It is said that phenobarbital have a sedating tendency. Well, that's true, but as long as you stay with a therapeutic range between 10 to 20, it's rarely cause a severe sedation. Respiratory suppression may be seen in high blood level. Then long half-life, so it's prone to have a withdrawal seizure and difficult to discontinue. It's hepatic enzyme inducer. Not many people know that phenobarbital could paradoxical aggravation of a seizure in higher blood level. Usual adult dosage is 90 to 100 mg a day. Primidone is a phenobarbital prodrug. Primidone metabolized into phenobarbital and phenylethylamide, both of which are anti-epileptic. For this metabolic profile, it is better tolerated than phenobarbital. Primidone is converted from phenobarbital. Rule of thumb is 100 mg of phenobarbital is equivalent with 500 mg of primidone. Because it is proven less effective than carbamazepine in the VA study. It is not frequently used for treatment of epilepsy, but it's still useful. Utilization of primidone for essential tremor is also seen a lot. Now let's talk about the benzodiazepine. There are lots of benzodiazepine in clinic, but now I concentrate only diazepam and lorazepam for treatment of acute seizure. Which one would you try and why? The diazepam is fat soluble, which is easily absorbed from the mucous membrane. Because it is fat soluble, it is easily absorbed from the mucous membrane per rectum or per mouth under the tongue. It's quicker in absorption and redistribution due to fat absorption. For the best result in treatment of status epilepticus, I will give IV diazepam and IV dilantin at the same time. Now, lorazepam is on the other hand water soluble. It's slow absorption from the mucous membrane because it does not it's not fat soluble. A little longer half-life than diazepam, but no redistribution to fat tissue. Intramuscular injection is not recommended in either agent. Action is slower than diazepam in treatment of status epilepticus, but I prefer to use lorazepam for treatment of status because it does not cause fat absorption to the fat. Phenytoin, dilantin. What is good about phenytoin? It's inexpensive, $12 to $15 per 1 month supply until 10 years ago. Recently, I heard that one patient was charged $170 for 1 month supply of phenytoin, which was kind of shocking. I think that the pharmacological industry changed the price. Phenytoin is a sodium channel blocking agent and very popular classically, and they said easy to use, but it's not really. Now, phenytoin is nonlinear kinetics, follows a Michaelis-Menten curve. Albumin bound 90%. So only 10% of unbound fraction is pharmacologically active. Side effect is ataxia, hirsutism, gingival hyperplasia, ataxia, calcium depletion, and it is a hepatic enzyme inducer. Rule of thumb is 1 unit of free dilantin is equivalent to 10 units of total dilantin level. In giving this via IV, keep in mind that this have a high pH, 9.7, which desolates the vein. You should use a fast phenytoin instead if you expect to a prolonged period of IV infusion. Acute high-dose infusion may cause a cardiac arrhythmia because of the solvent, not because of a phenytoin per se. Now, never give phenytoin via IM because it causes severe, sharp muscle ache. Carbamazepine is Tegretol. Carbamazepine is relatively inexpensive and linear kinetics. If you double up the dose, the blood level double up. Sodium channel blocking mechanism is well known. Now, carbamazepine causes induction phenomena, which means that your liver starts to recognize carbamazepine as a foreign body, so it facilitates the metabolism by itself. So if you keep using that carbamazepine in chronic basis, it slowly decreases the blood level of carbamazepine. What to do with it? That simply means that the patient's liver is healthy. Just paddle up the maintenance dose of carbamazepine. What's the side effects? Leukopenia, liver enzyme abnormality, ataxia, nausea, hyponatremia, especially patients who have an intracranial lesion or intracranial hemorrhage. It causes subtle higher cognitive function deterioration. It sometimes rare but causes seropositive conversion of A and A. Carbamazepine causes nausea and vomiting due to generation of 10,11 epoxide in intermediate metabolites. This could be the pediatric trivia, as Neurontin the carbamazepine level is pushed up by use of erythromycin. So try to avoid the use of erythromycin in a kid who is on carbamazepine. And it have to be remembered that carbamazepine makes the primary generalized seizure worse. So please do not use for absence seizure, JME, and primary generalized seizure. Oxcarbazepine is prodrug of carbamazepine. Oxcarbazepine does not produce epoxide, so it does not cause a severe nausea, vomiting. Otherwise, it is similar to carbamazepine. Valproic acid, Depakote. What's good in Depakote? It's a broad spectrum. It can be used for primary seizure, seizure disorder, and also for that partial complex seizure, and well tolerated and easy to use. And the chemical structure look like that in the right hand side. It's saturated fatty acid. So a few word of caution of valproic acid. Side effects include hair loss, weight gain, polycystic ovarian syndrome. So therefore, young women start hate you forever. Thrombocytopenia, which could be reversible. Hyperammonemia and tremor, which may mimic the Parkinson's disease. And it also should be noted of relatively high teratogenicity, especially spina bifida. So be cautious in prescribing this to young female which expect a pregnancy at any time. Do not use it if age less than 1 year old because of insufficient fat digesting enzyme, as chemical structure of Depakote is the saturated fatty acid. It may be the risk of pancreatitis and hepatic failure, but such side effect may not be encountered in older kids and adults. Valproic acid is also prescribed for bipolar disease and migraine prophylaxis. Valproic acid is a hepatic enzyme inhibitor, not inducer. Lamotrigine, its action is similar to phenytoin, and it works for sodium channel blocking and also glutamate receptor blocking, and less protein binding. It's easy to use, less toxic. Remember, this is still a potent anticonvulsant. The most significant side effect is Stevens-Johnson syndrome. Concomitant use of valproic acid increases the risk of Stevens-Johnson syndrome because valproic acid inhibits lamotrigine metabolism. Gabapentin. Gabapentin was designed to mimic a GABA molecule, but this did not work on GABA receptor, but it works on the glial GABA reuptake it inhibits. Relatively weaker anticonvulsant, weaker than carbamazepine, so it's not used aggressively in intractable seizure treatment by epileptologist. However, it still works the best in patient who has a chronic secondary epileptogenesis. It's also helpful for diabetic neuralgia. Side effects are weight gain, GI upset, and ataxia, especially in elderly. Pregabalin works like a gabapentin. It is calcium channel blocker, not GABA enhancer. Anticonvulsive effect is moderate. Side effect is GI upset, also used for treatment of a CNS fibromyalgia. Topiramate. Topiramate is multimodal AED. It is sodium channel blocking and GABA enhancing agent, but also, most significantly, it is glutamate receptor blocking of AMP type. AMP type glutamate receptor is short-acting excitatory receptor. The duration is milliseconds degree, while the NMDA receptor with slow tonic excitation block excitation, its duration matter of hours or even days. The NMDA receptor is blocked by felbamate. The topiramate is broad spectrum agent, and it can be used for primary generalized seizure treatment and partial complex seizure. You may start from a small dose like a 25 milligram a day and with slow titration. Side effects of topiramate are important to remember because it could be your board examination. It may cause a word-finding difficulty, dysnomia. Peripheral neuralgia characterized by burning, sharp pain sensation in the tip of the finger, so it is called St. Elmo's fire. Topiramate is known to cause weight reduction, which is sometimes welcomed. Topiramate may aggravate glaucoma, especially open-angle glaucoma. Topiramate causes kidney stone, and sometimes it paradoxically aggravates drug-resistant complex partial seizure, probably up to 5% of them. The common denominator of seizure exacerbation by topiramate is bilateral seizure development. Now, felbamate on the contrary to the topiramate. This is NMDA type glutamate receptor blocker. This is broad spectrum just like a topiramate. We believe that the felbamate inhibits the seizure propagation. Felbamate blocks a bifrontal hypersynchrony and mimicking the pharmacological corpus callosum. Felbamate is a good single efficient agent for treatment of Lennox-Gastaut syndrome. A sad story of a felbamate is just like that, so please read it if you have time. Zonisamide. Zonisamide is made in Japan, first of all. It was developed in Japan in 1980s, and then it is introduced to the United States in 2002 or 3. This is a wide spectrum and safe anti-seizure medication, and mechanism was calcium channel blocker. It have a long half-life, so it allows us to take once a day. So this is good for elderly or patient who was questionable compliance. Rare side effects include kidney stone and anhydrosis. Levetiracetam. It is known as Keppra. Keppra is now very prevalent in our medical society. The mechanism was inhibit synaptophysin, which inhibits release of excitatory neurotransmitter, and people believe that this AED is the most safe, and indeed it is true. It has high LDH and high LD50, and also have the property of no interaction with other medications. But side effect is not ignorable, which include depression and disabling psychosis and suicidal ideation. Use of this agent for status epilepticus remains controversial. Levetiracetam was originally developed for treatment of myoclonus, and there was no effect in acute seizure model in animal studies. So initially it was discarded in the drugs substance selection. Later it was rediscovered, having an inhibitory effect on kindling process. So it was believed that more beneficial for chronic seizure instead of acute symptomatic seizure. Just for FYI, pre-market study shows an increase in incidence of upper airway infection. Lacosamide is slow sodium channel blocker, 77% of retention rate in 1 year, that is good. And IV formula is available. Status epilepticus may be treated successfully by this up to 56%, which is not bad. And it works for Lennox-Gastaut syndrome as seen, but just like a topiramate paradoxically aggravates a seizure, this lacosamide could cause a paradoxical exacerbation by 16%. The exact reason is unknown, so it's still under investigation. Perampanel is known as Fycompa. Fycompa is non-competitive AMPA receptor blocker. Bioavailability 100% and half-life is 105 hours. Its protein binding 96%. And side effect includes aggression, hostility, and homicidal ideation. So it's scary, isn't it? However, this side effect was encountered in the pre-market study when the dose was started from 10 mg. But in my practice, I start from the 2 mg once a day and then increase the 4 mg 2 or 3 weeks later and slowly escalate the dose. As long as you slowly increase the dose, such side effect may not happen. And it's actually very safe and efficacious and highly recommendable for intractable seizure treatment. Esricarbazepine is prodrug of oxcarbazepine, and oxcarbazepine is prodrug of carbamazepine. It is for the complex partial seizure, not for generalized tonic-clonic seizure. It is basically good drug, but problem is very expensive, like $700 a month. Vigabatrin is an irreversible inhibitor of a GABA transaminase, which come to your board question. This medication is for intractable seizure, which was almost a surgical candidate. But for some reason, if patient does not want to have a surgery, I might prescribe this medication. But problem is, this is a strong, unignorable side effect, like intramyelin edema, peripheral visual loss, which could happen up to 50% of the user. The off-label use of a cocaine addiction is seen. The thiagabine is known as gabitril. It's also for intractable seizure. The side effect is ataxia, myoclonus, and paradoxically, ironically, it makes seizure sometimes. Clobazam was available since 2011 for treatment of Lennox-Gastaut syndrome, but it's also helpful for intractable partial complex seizure. It has been available in European countries since 1980s. And clobazam is like benzodiazepine. It's GABA-A enhancer by combining to alpha-2 subunit. It is a very good drug in some sense. It's potent, but narrow spectrum of efficacy. Tachyphylaxis is less likely. This is a first-line drug for Lennox-Gastaut syndrome, but it's also a reasonable option for drug-resistant seizure. Rufinamide is for Lennox-Gastaut syndrome, and then efficacy is low to medium. It's not strikingly efficacious medication. Propofol is not outpatient anticonvulsant you may use, but you may see this medication in treatment of status epilepticus in ICU, and less toxic than short-acting barbiturate, and occasionally aggravate the partial complex status epilepticus. So you should use a long-term EEG recording while you treat the patient with propofol. Prolonged use could cause a lactic acidosis. Dimax is not frequently seen in treatment of epilepsy, but indeed it is regarded as anticonvulsant in special case. Dimax is diuretics, but most efficient agent for catamenial seizure. Catamenial means that it relates to the menstrual cycle. How do you use it? Start from the smallest dose twice a day, starting since 2 days before menstrual cycle, and continue until 2 or 3 days after the menstrual cycle is over. It contains sulfur moiety, but it does not cause a sulfur allergy. Allopurinol is the last medication I explained here. Allopurinol is a gout drug and xanthine oxidase inhibitor. Well, believe it or not, allopurinol is categorized as anticonvulsant in European textbook. It is weak and less potent, but it can be used if patient is sensitive to the rest of the other anticonvulsant. And moreover, it possibly have a synergistic effect with topiramate. There are 17 anticonvulsants available in market, and the selection of anticonvulsant depends upon the judgment of clinical seizure presentation and seizure type and underlying pharmacological mechanism. This is the end of the presentation.